important part of our duty of care is to make sure that we take you through your operation as safely as possible and that your outcomes are good. And to that end, your investment front end is in preparation and optimization. And a couple of you, we've had this discussion today. If you have kind of not reached that goal, we will have to allow you to reach that goal. Okay, this is an elective operation, and it's important to make sure that before you go in, all the dots are crossed and everything is complete and the ducks are in a row so that you'll sail through. And so the preoperative testing, consultations, clearances are all kind of done, and then that last visit, once they're all completed, then you get the final consent to proceed. And part of this success includes that lifestyle change. We want to see that ahead of time, because what you don't want to have is someone coming off the street, going to a physician, saying, look, I want to have gastric surgery, and then the following week they're getting it. Okay, that is not the recipe for success. Actually, that's a recipe for disaster. It's a preparation, and you have to make some changes in your lifestyle and for yourself to assess and see how you successfully can manage this. And then with the surgery, you proceed and the transition becomes a lot easier. This is probably the most important step prior to surgery. This is controversial in some of the studies that have been done, but I can tell you a lot of the studies have suggested that 5 or 10% weight loss does help your surgery, does help your outcomes, and long-term your end results with weight loss. And particularly for men, because we have higher liver fat content, thicker livers, higher abdominal fat content, that 15, 20 pounds makes a big difference between having the surgery laparoscopically through keyhole as opposed to open, which means you have to go in and make a 6, 7, 8, 10 inches of an incision, 4 or 5 inch deep to get to where you need to. And that kind of scenario sets the patients up for more problems, such as wound infections and potential for hernias. So we want to do everything we can to get the surgery done laparoscopically, and that's why you want to get that 5 or 10% weight off. We all, of course, are aware of the side effects and problems associated with smoking, the peripheral vascular disease, heart disease, lung disease, God forbid, the cancers that are associated with it. But one thing that may not be very well recognized is that smoking does increase your ulcer rate, especially in gastric surgery, by 10 times. So we know there are studies that show that you can actually have a much higher percent of getting ulcers at the site where the surgery was. 10 times or higher. Healing slows down, and you have to be smoke-free at least 2 to 3 months. Now, this is a health initiative, so nothing would be more important than actually stop smoking. The difficult thing is that when you do stop smoking, often patients put 10 pounds, 15 pounds on. And if you've started at a weight that you were supposed to go down by 10, 15 pounds, and now you've stopped smoking and you've gained 10, 15 pounds, now you have suddenly 30 pounds to negotiate. But, it doesn't matter. All you need to think about is that end point. Where are you heading? Where you need to be? How safely you want to get there? And you keep working towards that. It may take you 3 months. It doesn't matter. You're going to be, please God, living for another 40, 50 years. That 3 months is an investment really worthwhile. And so you really got to aim for this, and you have to be completely smoke-free, okay? If you need help with that, your primary hopefully can facilitate that to transition you to something like Shantex and then beyond that. But that's a very important thing. Those of you who have had history of smoking will be nicotine tested as part of your protocol, and if it's positive, then we have to wait until you're clear. So very important. Also remember, it does increase your risk of blood clot formation, and you want to make sure that you reduce all the risks that will induce blood clotting. And the other thing that smoking does, of course, makes your postoperative recovery hard. And if you have been smoking, you have a lot more cough, higher incidence of breathing problems, pneumonias. So that's off the menu. You want to come off of all the non-steroidal anti-inflammatory drugs. This is a big group. If you don't know them, it's okay, you just go over the counter. There's always a little section of the prescription pharmacy side that is for advice. You say, look, I'm sorry, does this have an anti-inflammatories? So the big ones that everyone probably knows are ibuprofen, sold under the name of Motrin, Advil, or Aleve. Aspirin is the main, if you like, component of the anti-inflammatory tree. Other things like naproxen, which is sold under the name of Excedrin. Things that are on prescription, Celebrex, Mobic, indomethacin. These are all drugs that work very similarly, and they do increase risk of ulcer formation. They all salt and water retain. They can push your blood pressure up. Long term, they can compromise the integrity of the kidney function. So all of these things are things that we want you to come off of. Now, the problem, of course, is most patients who have trouble with obesity have trouble with their joints, they have pain, and they will have, over years, been kind of taking these and become, almost bonded and dependent on these. So you have to stop and transition yourself to Tylenol over the counter. And if you need something stronger, you'll get prescription like Vicodin or Tramadol or Percocet. But typically it's for a short period of time, because once you get the surgery, you lose weight, your joints feel better, and often you wouldn't need a lot of these drugs, and hopefully minimal amount of consumption. Now, for period cramps and things like, problems associated with that, alternatives will be fish oil that will help to thin the blood a little bit, vitamin E or primrose oil. So there are alternatives, herbal, that you can try, and some people find it very helpful. But come off the anti-inflammatories. Another class, a very important group, is the hormone replacement therapy or oral contraceptive pill, the hormonal groups. They have a higher incidence of blood clots. There is association with these groups of drugs, and you have to avoid taking them for 2 months before surgery and not take them for 2 months after. Now, I often mention this, and there's always, every couple of months, a patient that I guess somehow it didn't register, so I want to really make this very clear. This includes the injection variety, it includes the patch, it includes the oral preparation, okay? It really doesn't affect a cream as much, or an inserted coil, an IUD that has got hormone impregnated in it. It's mainly the oral tablets, the patches, and the implants and the injections. So if you are getting these, make sure that you're off of them for 2 months before surgery, and you remain off for 2 months after. Now, fertility goes up after surgery. And again, that's one of the other things that no one believes us on this. And I have, I think, 8 patients that will stand here and tell you that it is true. A lot of couples who may have wanted to try and get pregnant and had difficulty afterwards, they find that it's a lot easier. So during that first year after surgery, you want to not get pregnant, because the pregnancy will, of course, reduce the rate of weight loss, and the babies are born smaller in size. They're normal, but they're a bit smaller. And so after the year, it's okay. But during that 1 year, you have to use some sort of a contraception modality. And as we just said, 2 months before and 2 months after surgery, you don't want to be using any of these chemicals. So you have to rely on barrier methods, condoms, caps, an IUD, timing of the ovulatory cycle, things like that. And then after the 2 months, you can go back on these hormones. Now, absorption is not as good after gastric bypass, particularly of these hormones. You have to probably best choose an alternative method after that 2 months phase. Injection, implant, patch. And remember, they do make you gain a little bit of weight. So don't be surprised. I had a patient yesterday who's been put on this, and her weight loss just abruptly came to a standstill, and she was panicking. So it does happen, but it's kind of a balance. You have to decide, do I want to do this? Or so she said, I'm going to have my partner go under vasectomy. So she had to negotiate. Do I push my husband to go get a vasectomy, or do I? So that's something that you have to talk to your family about. So it's kind of become battle of wills, as they say. We're talking about the oral preparations. Now, if you have in the past needed these drugs and you may be requiring them again, remember one thing. You don't want to be ideally on a steroid tablet within 8 weeks or 2 months of surgery, because there is a very slight higher rate margin of complications associated with surgery, leakage, and wound problems. So if you are, for some reason, given these drugs, you just pick the phone and say, look, Dr. Yadegar, I'm on steroids, postpone my surgery by a couple of months, okay? You really want to do that. So make sure that that's the case. And also remember, this does not apply to steroid injections in your knees or in your back, or if you're on inhalational asthmatic therapy. Those are smaller doses, it's okay. We're talking about high 10-day, 2-week course of oral steroids, okay? So medications that are time release, ER, extended it says, or CR, continuous release, or SR, slow release, they typically won't absorb as well after these operations. So if you are on these class of drugs, take them off, or i.e. go back and have them switched over to the regular formulation. The regular vitamins and supplements that you buy over the counter are typically heat compressed, very dense molecules, and relies on a lot of stomach acid and juices to break it up before it gets absorbed. After these operations, a lot of the acid of the stomach is either diverted or reduced, and so you won't break these the way that you would have normally, and you won't absorb them therefore the same way. And what you need to do is to get the formulations that you will absorb better. And there are many of those formulations out there. So the chewables are the classic ones. So it should say on the bottle, chewable multivitamin, okay? Don't get a vitamin and chew it. So Dr. Yadegar said chewable, okay? Because it won't absorb as well, okay? So get one that says chewable. Sometimes you guys find them a bit chalky. So you don't like that, there are crystal. There are powders that you can put like crystallite in water. Drink it that way. So maybe that's something that you like. There are liquid varieties, many liquids now. Some are horrible, and some are very palatable. I never want you to go through an operation and get something that your heart is not completely bonded with, okay? So the answer is there's never an obligation. Even on the day of surgery, and I've had 2 or 3 times in the last 5, 6 years where this has happened. Even on the day of surgery, something happened, you are uncertain, or you want to change the date, or you want to change your surgery and we can't do it, it's okay. As I told you, this is elective. Not having the surgery for another 6 weeks is not going to detriment you. Just the pain in the neck because you have to reschedule work, but you've got to have the surgery that you feel completely comfortable with. Of course, if you weigh 400 pounds and have diabetes and blood pressure and cholesterol and you were supposed to get a bypass, and we know that that's the best outcome with the bypass for that patient, but the patient says, look, I want the band because I'm scared and I don't want to get anything, I'll tell you, look, you know what, the band is not a good choice for you. And if you absolutely want it and I don't feel that's the best match, I would just tell you, okay, we need to then have you see someone who will be the person who feels comfortable to do that operation for you. So you have to make sure, though, that the choice is the right choice, but 99% of the time your choices are the right choices. You yourselves will come to that decision, and as long as that's the right choice, we certainly would help and facilitate that. But if it's not, we will still facilitate it, but through someone who will give you a second opinion on things. But again, on the last day, if there's a change, that's okay. But prior to that, I hope by the time you come to the pre-op, you would have already had all of those discussions and negotiations and you know where you need to go.